membrane. We'll be talking about starting right from how to prepare your own amniotic membrane and the various surgical applications of amniotic membrane that is done. I'm Soham and I'm joined by my co-instructors Dr. Tuhin Chaudhary and Dr. Aditya Pradhan. Dr. Nidhi could not attend due to some last minute commitments, and so I have no financial interest in this talk. And this is the basic course outline. I'll be talking about the preparation part of it, and then Dr. Tuhin and Dr. Aditya will be talking about various applications. And we'll be going over the Dr. Nidhi's presentation also on where AMT is used as surgical adjuncts in various miscellaneous scenarios. So a little bit about the history of amniotic membrane. So it has been described over 100 years back by Davis in dermatology. And first ophthalmic use was documented by D. Roth back in 1940s. And then in 1946, Sorsby and Simmons described use of amniotic membrane in acute chemical injury. However, it was not popular till 1990s and early 90s when Schaefer-Seng really popularized it. And you can see how the PubMed publications also really spike up from the late 90s and early 2000s. So that's how over the last two and a half decades, amniotic membrane has really found its place in ophthalmology, not just cornea and surface, but now slowly in the other avenues, other subspecialties also. So if you look at the basic cross section, if I ask you what ultrastructure this is, you can guess this can be a skin, this can be cornea, this can be conjunctiva, and this can be amniotic membrane. So it's really this similarity of the basic pathology that helps make amniotic membrane such a versatile tool. And this is the structure. It's so similar to the cornea and conjunctival epithelium. So you have an epithelial followed by a basement membrane there, then a stroma which has got a compact fibroblast and a spongy layer, and finally there's a choroid which is again sort of like a basement membrane. And the beauty is amniotic membrane is translucent, it is avascular, which makes it largely non-inflammatory, non-immunogenic. And there is some epithelium with microvilli, and the collagen structure again matches that of the cornea and conjunctiva. And then the stroma also allows for a lot of water retention. So the mechanism of action, it has got a multifactorial therapeutic action. Firstly, there are some of these physical attributes. There is very limited HLA expression on the surface, so you do not, even though it's a foreign tissue, there is no immunogenic response by the body. It's translucent. A good prepared amniotic membrane is translucent. It will allow for you to examine what is happening underneath the amniotic membrane. So we have done a slat. You can see how the explants are growing or how the epithelium is healing in a chemical injury. It has got mechanical support, and the stroma really allows for a lot of moisture retention. The basement membrane, the collagen composition is similar to that of the ocular surface. And it has got a lot of these growth factors and chemokines, and the best part is even after storage at -80, the properties of these are not lost. So what these chemokines really help is and helps in the cell growth. It helps in all the stages, differentiation, adhesion, and the cell proliferation. It has got antifibrotic properties, it has got anti-inflammatory properties, it has got anti-angiogenic properties, and it has got antimicrobial properties. So for any of these chemical injuries, acute Stevens-Johnson's like syndromes, whatever the disease pathology is, amniotic membrane has an answer to stop those basic pathologies right from the beginning. So that's why it becomes such a beautiful toolkit. The types of surgeries, you can have basic inlay technique where it is used to fill in a defect. You can have an onlay or an overlay technique where it is used to cover an unhealthy surface. Or it can be a combination of two of the techniques where it is used to fill in a tissue defect plus cover the thing. Now whether to use it in an epithelium down or an epithelium up forms, various surgeons have their own interpretations, and what we have seen from literature is both of them seem to work equally well. The types that are available, mostly we have the freshly harvested, which are then preserved at -80. The other options would be the lyophilized as freeze drying. There is limited availability in India. Advantage is that it can be stored in room temperature. However, the efficacy is not as great. And we have also this Oro Amserter developed by Dr. Bhaskar Rai Chaudhary. So this is basically a sort of a clip-on ring which converts an amniotic membrane sheet into something like a Procara. So this can be used as a symblepharon ring in these acute cases. So delivery things, again Procara not very commonly available, but you can source it from outside. And this finally people have been experimenting with amniotic membrane extract drops. However, there has been some regulatory warnings from the FDA in 2023. So how to prepare an amniotic membrane? If you have a basic microbiology lab or an IBank lab setup, you can do it very easily. You need to have a good rapport with an obstetrician who will be supplying you with the placenta from an uncomplicated cesarean section. And usually these are patients where all the serology is negative antenatally. However, we do reconfirm the serology from the cord blood. Few years back we were doing COVID PCR. Nowadays we have stopped doing it. And best to prepare amniotic membrane on the same day where the C-section is done. And so your lab technicians should be planning things out accordingly. It takes up over around 3 to 4 hours entirely to do all the steps. So what we need is basically some basic chemistry setups like graduated flask cylinders. This is one important instrument, the filter pump with sterilized tubing, some filter paper, a good quality pH meter, and a good quality digital weighing scale, because this is where the most important, where we'll be refining the media. Sterile bottle caps and a laminar flow hood. So these are the basic reagents that is required. So the DMEM is the most important part here. Other than that, we need sodium bicarbonate. Antibiotics, we do streptomycin, penicillin, and amphotericin B, being a tropical country. And then we need some good filtered water, glycerin, normal saline, nitrocellular paper available as sheets, and then sodium hydroxide and hydrochloric acid for fine pH adjustments. So this is how it looks like. So these are basically the spoons that is used to scoop out the instruments. This is all happening under the hood, and these are the various cylinders that are required. So we have the filter paper. These are the antibiotics and antifungal agents. Then we have the sodium bicarbonate and HCl, various swabs and cleaning parts. So we start off by preparing the media for the DMEM. So the instructions are available on the material itself. You have to mix it in certain proportions. And what is important at all the steps is measuring out these ingredients exactly according to the manufacturer's instructions. And finally, after each of these steps, we do check the pH of the media. So if the pH is not adequate, then if it is too acidic, we add little bit of sodium hydroxide, or if it is too alkaline, we add a little bit of HCl. So finally, with the pH indicator, you should have this bright red appearance, and the pH should be within 7.4 to 7.6, in that range. That's where we want the pH to be at. Then similar to what is done for the corneal storage media, we add the antibiotics, and we also add an antifungal agent to this. The amphotericin B is also added to this. So this is a lot of just meticulously measuring out the ingredients. And this is the digital pH meter. We want it between 7 to 7.4. And if it is not adequate, we have to just fine tune it. And then after everything is prepared, then we pass it in this filtration pump system. So we add the filter papers in the middle of the device. And then what it does is, the pump basically forcibly drives the fluid across the thick filter paper system. So this takes some time, and while this is going on, we go ahead with the other steps, next steps of the preparation part of it. So next step would be the serology part of it. So this is the amniotic membrane, which is brought in we try to maintain a sort of a cold chamber of sorts, and then the cord blood is taken. So we do the regular serology, HIV, Hep B, Hep C, and syphilis. So although this is done for the mother antenatally, we repeat it with cord blood for our own safety and record keeping also. After this, we move on to the thorough cleaning process. So this we have to be very careful, as in it has to be very meticulously done. So the rinsing of the surface of the amniotic membrane, this is with just plain saline with some amount of antibiotics mixed in that normal saline solution. This is repeated 3 times, 4 times till you're assured that all the clots have been removed from the surface. So once that is done, the amniotic membrane over time slowly tends to get released automatically from the rest of the placenta, the chorionic surface. This is what we are looking for. So you can see The technician slowly removing the amniotic membrane from the underlying chorionic surface. This can be done with just blunt dissection with your fingers. And once you have a clear sheet like this, you stick on a nitrocellulose paper. This is about 2 inches by 2 inches. And then cut out a strip of amniotic membrane. Nothing too difficult, just takes a lot of patience and needs 2 technicians. So this is then repeated throughout the rest of the sides of the amniotic membrane. Usually, if you are being very careful, you can easily harvest around 30 to 35 strips of amniotic membrane from one placenta. And the advantage of preparing your own is you can prepare multiple sizes of these also. So normally, for most commonly, we keep it as a 3 into 2.5 into 2.5 centimeters squares, but sometimes some of the squares we keep it as a larger ones also for when we are doing more extensive surgeries. So rather than when you are sourcing from outside, you don't get that freedom. So once this is done, and by the time the filtration process is complete, so this is then slowly kept into these small glass vials. These are filled up. These can be re-sterilized, so you can keep reusing them also. And then these are cut into the 2.5 into 2.5 centimeter strips, and then they're kept in the vial, and then we label them with the date and time, and also then cap them with the heat shrink wraps, and then these are stored at -80. So then coming to the final part of it, that is quality control, storage and distribution. So before distribution of any of these tissue, we make sure that it is culture negative, both blood agar and fungal PDA or SDA. Then in -80, it can be easily stored for 6 months. If you do not have a -80, when at -20, it can be stored. However, the storage time reduces maybe to 1 to 1.5 months. Maintenance and distribution log, this is for our own record keeping. Adverse reactions log, in case post-operatively something is happening, we inform our lab about what has been going wrong, and a freezer temperature log just to make sure that the temperature is maintained over time. So definitely AMT is a versatile tool, and making your own amniotic membrane is nothing too difficult in a very standard microbiology lab setup. I will definitely encourage the bigger hospitals and institutes to take up this as their own project, and you can also distribute to your local cornea colleagues as well. And having your own facility definitely gives you a lot of more freedom over how to size and when to time it, and also pricing issues as well.